Good morning to everybody. It's a great pleasure for us to start this international symposium of the National Academy of Medicine in Brazil and the China Anti-Cancer Association. And the topic of our symposium is health, aging, and cancer control. I would like to call to sit together with us the Vice President of the Chinese Anti-Cancer Association, Ying Wang, please have a seat. Be careful because there are some steps here, please. And I would like also to call to sit with us the academic Maurício Magalhães Costa, please. And continue with the composition of the table, the president-elect of the International Association for the Study of Lung Cancer, Professor Caicun Zhou. Please have a seat with us. And then continuing, we would like to call our Brazilian associates, Professor João Viola, representing the National Institute for Cancer, please. Professor Santini, also from, well, he was the director of INCA, but now he is Henk Slako, please have a seat with us. And Professor Tatiana representing the Fiocruz, please. Then I would like to call the academic Maurício Magalhães, which will say some words for us. And before, I would like to tell you that everybody which will talk should talk close to the microphone to facilitate the work of our translator, please. Okay, thank you very much.
Thank you, Mr. President, for this opportunity, for the support for this international symposium. I have been in the last years becoming more and more close to the China Anti-Cancer Association with the Rings Lacom, that Professor Santini and Walter Zoas are here, and Professor Eduardo Cassap. We became more friends and we are more close. And now we have this fantastic opportunity of this first international symposium together. And after this session, we will sign, the president will sign together with Professor Wang, memorandum of understanding between both institutions. And this memorandum established that we will start to have periodically scientific meetings, interchange of training for students, for young physicians. And I think it's a good opportunity that is open for the future. And I really thank very much the China Anti-Cancer Association, also Professor Diamond Fan, the president, unfortunately, could not come, but he's supporting very much this initiative. And then I thank you for all of you and for you, all of you that coming, our academicians that are supporting us and all the audience that's, well, we will have, we could start? Okay. Please, it's a really pleasure. And thank you very much, Mr. President.
Okay, Professor Wang, could you just have words, please?
Okay, thank you. Dear President Eliete, Bouskela, Professor Maurício Costa, and distinguished academicians of the National Academy of Medicine Brazil. Ladies and gentlemen, good morning and good evening for online participants. It's my great honor and pleasure to lead the CACA delegation to be here to visit the National Academy of Medicine and the Memorial Center. Thanks for your invitation and the hospitality. Brazil is the largest and the most influential country in South America with a unique culture and a beautiful scenery. This year marks the 50th anniversary of the establishment of a diplomatic relationship between China and Brazil. So it is good time for CACA to visit Brazil today. As we know, M has celebrated on 195th anniversary on June 30th this year. Congratulations on your significant achievements. This is the year of the 40th anniversary of CACA. Over the past decades, CACA has developed very fast, especially under the leadership of the President Dai Mingfang, CACA has made great achievements in the following aspects. And right now, CACA have about 800,000 individual members and over 200 professional societies and 31 anti-cancer associations were set up in each province in China. And the Chinese Congress of Holistic Integrative Oncology is the annual meeting of CACA, which was launched in 2000. And it is the largest conference in cancer field in China. Last year, the conference brought together nearly 5,000 speakers from China and abroad and attracted 165,000 participants in main venue and branch venues across China. During the conference, Professor Maurício Costa was invited to attend the academic forum and gave an excellent presentation. This year, the Congress will be held in Xi'an, which is an ancient city with 3,000 histories in China. It will include more than 20 international sessions, and the conference is expected to draw over 40,000 participants on site. We are very honored and pleased to invite President Eliete, Bouskela, and Professor Costa to attend the Congress in Xi'an in November this year. Since 2022, CACA developed CACA guidelines for holistic integrative management of cancer. It includes 113 guidelines covering 53 types of cancer and 60 techniques. And we promoted CACA guidelines in China by delivering 100 lectures with over 1.6 billion participants on site and online. Meanwhile, we jointly host anti-cancer summits with 5 continents. The summits have attracted over 128 million online viewers from 35 countries in total. CACA launched the English journal named the Holistic Integrative Oncology in collaboration with Springer Nature. It's open access, peer-reviewed journal on all aspects of oncology and free of charge for authors. By now, 99 articles in 15 issues have been published. The current number of access is over 140,000 across 156 countries. This month, we just published Professor Costa's commentary. We hope to include more outstanding manuscripts from Brazil. CACA launched the National Cancer Week on April 15th to 22nd annually since 1995. Various activities are organized by CACA across the country. Thousands of medical institutions and professionals participated in the campaign each year. Last year, around 800 million people have been attending these events. Meanwhile, CACA also joined the Global Cancer Week, such as US is Cancer Day, Latin American Global Cancer Week, and the London Global Cancer Week. We hope with our joint efforts, we will make contribution to decrease the cancer morbidity and the mortality, and improve the quality of life of cancer patients, not only in China, Brazil, and worldwide. CACA values the relationship with M. We are privileged to enhance collaboration and develop relationship by jointly host the symposium and signing MLO. I believe today's scientific symposium will provide a good opportunity for Chinese and Brazilian scientists to share and exchange the latest research findings and achievements, to improve better understanding of each other, to facilitate future collaboration between two organizations. I believe by working together, CACA and M will make a contribution to human health in the future. Finally, I wish this symposium will be a great success. Thank you. Obrigada.
Now we would like to have some words from the president of the National Institute of Cancer of Brazil. Please, Professor João Viola.
First, good morning, everybody. First of all, I would like to congratulate all the academics here, also the Chinese delegate in name of our President of National Academy of Medicine, Eliete Bouskela. Also, I would like to congratulate all the efforts for do this very important event about cancer. Brazil and aging. Brazil is a very important in transition of epidemiology of cancer and other disease related to aging. Our population is getting old. Also, we have all pressures for develop cancers in Brazil, and our institution include INCA, our National Cancer Institute, and the Ministry of Health has a tremendous effort to control and understand this disease in Brazil, that now it is a very important public health problem in our population. Then this collaboration between other countries, including China, that is definitively, we have a very important relation with scientific, economics, and close together with this country that is definitively is going to go together to understand and help for this problem. Then I deserve for everybody a very good meeting today, and I'm pretty sure that it will come very important findings in the future. Thank you very much.
Thank you, Professor Viola. And now soon we are going to start the symposium. But before we do that, I would like to thank again the Chinese Anti-Cancer Association to come here, because one of the objectives of this academy is to increase its relationship with academies all over the world. So it's a great pleasure for us to receive all of you here. Thank you very much again for making the effort to come to Brazil and we look forward to a very good symposium and a very fruitful collaboration. Thank you again. Professor Maurício Magalhães, please continue calling for the participants. Thank you.
Thank you, Professor. When we decided to organize this symposium, it was to suggest, of course, cancer, but also the question of aging. That's the health aging is a very important, perhaps, tool to prevent and allow the early diagnosis of cancer in the future. And then we invite our Professor Alexandre Kalache, that's a specialist in aging. He has been the coordinator of this sector in the World Health Organization for many years. And he is in São Paulo, but he will start now his presentation. And he has a very good experience in his career between cancer and aging. And then we'll do a very good introduction about this topic as longevity, revolution, how to respond. Then I ask Professor Alexandre Kalache to start your presentation. And thank you very much for your support for this meeting.
A very good morning to you. I'm really very, very sorry that I'm not with you presentially for reasons that I could not control. I had to come to São Paulo, but I'm delighted to be here. My greetings to my dear friend, to the President of the Academy, and to all my fellow peers at the National Academy. And also a very welcome to Brazil, to the delegation from China, a country that I had the pleasure and privilege of visiting many times. Together with Brazil, China is one of the three countries that will age fastest over the next 3 decades. So we have a huge responsibility to get our house in order to respond to what I call the longevity revolution. Next slide, please. I apologize that I have a technical problem where I am unable to share the slides. I will need help from you. Well, health and well-being within the context of revolution. Why I am using this word revolution? Revolution is something that happens all of a sudden, abruptly in a society, and from there on, the society is not going to be the same. This is what is happening in relation to population aging. Next, please. You can see here that in 2015, only one country, and that was Japan, had more than 30% of the population aged 60 plus. Over the next few years, up to 2050, we will see more and more countries, including China, including Brazil, that will have more than 30% of the population over 60. Next, please. It's not only the number of countries that will join Japan, it's also the speed of the global population. You can see these arrows. The first one shows France, and it took 145 years for France to double the proportion of older people from 10 to 20%. Brazil and China will do the same in less than 20 years from 2010. It's a tremendous challenge how to respond to this very fast aging population, something that for developed countries took more than 6, 7, 8 generations and will do in only one. Another way to view these revolutions, comparing a country like Brazil with Canada. In 1950, Brazil had much less than half the proportion of older people than Canada. Next, you can see that we are now in 2015, 2020, with about half Canada 25%, Brazil 12%, and the next. But by the year 2050, if anything, Brazil will be slightly older than Canada, a big country that has the basics in order in terms of jobs, education, the environment, while Brazil will continue to have many problems that Canada has already overtaken. And yet in Canada, there is not a single university without a very vibrant center for training and research on aging. While in Brazil, we can count on one hand the centers of excellence on population aging research. We have a long way to go. The next, please. If I could put in a nutshell, developed countries first became rich and then they aged. Developing countries are getting older before the majority of the population can be considered rich. That is the revolution, that is the challenge. The next, please. Life expectancy at birth and at all ages continue to increase, while total fertility rates in 98 countries, that was last year, we have probably already reached 100 countries, have reached below replacement level. That is, the couple is not producing at least 2 children in order to be replaced. And in terms of numbers, in 2015, Brazil had a population aged 60 plus, about 24 million. In 2065, that is 50 years later, the total number will increase to 78, from 12% to 33.9%. All the other age groups will decrease the relative proportional participation in the population. The only group that is going to continue to increase from now throughout the 21st century is the population 60 plus. The next. Let us look at total fertility rates. In 1975, that is, for me, an important year. It was the year that I moved to England to do my post-graduation, my PhD, always on aging and in cancer. The total number of children a woman would have by the end of her reproductive life was about 5.7. By the year 2000, only one generation later, 25 years, it had reached below replacement level, that is less than 2. And total fertility rates has been below replacement level ever since. So that is already one generation with less than 2 children per woman. The next. Important to say that the number of children a woman expects to have at the end of her reproductive life will vary according to the total number of years of formal education. And women with more than 8 years of formal education will have about 1/3 of the total number of children that a woman with less formal education will have. These children are precious, and I want to point this very important stress and prioritize, because the future, to a large extent, for a country like Brazil, depend on what is going to happen to education of these children, which are the future. And failing that, what we can do in order to continue the process of development. Next, please. And some of you may think, well, 2050 is a too distant future. The next. No, it's not. If your age is 34 today, you will be 60 plus in 2050. And you know that time flies. The next. Let us look at 2065. The next. In 2065, someone aged 34 today will be my age in 2068. And I do hope that you will be active and healthy, contributing to society, sharing your experience and knowledge, because you will be needed. As we will have less and less young people, it's absolutely critical to ensure healthy and active aging, because that is the group of the population, I repeat, that is going to continue to increase in our countries. The next. Brazilian and Chinese families are growing vertically. Large horizontal families belong to the past. The next. In my childhood and adolescence, another person was at the top of the family pyramid with a very broad basis, lots of young people and few at the top in older age. The next. That is the picture in my family. You would become old when you would turn into a godparent. And you would have lots of children, lots of spouses of these children, lots of grandchildren. This is an ordinary day-to-day lunch at my grandfather's house. And this picture is the same in China, in Thailand, in other developing countries, families that no longer exist except in our imagination. The next. At the age of 60, a person is still expected to live a third of his or her life. That is too long a period of time to be wasted. The next. It is inconceivable to waste this additional third of our lifespan. All the efforts, individual and societal, are needed to maintain autonomy and independence for as long as possible. And that depends on policies, public policies. The next. It is a fact that our lives are becoming longer. It's also necessary to make them broader. Next, with more choice, with more opportunities. And this challenge is for the whole society, the public sector, employers, civil society organizations, the media, and very importantly, as I am speaking here at the Academy and addressing the Chinese Association for Prevention and Combat of Cancer, the Academy. We have a fundamental role to play in all this. The next. The defining demographic trends of the 21st century are aging, urbanization, and increasing inequalities. I'm afraid to say inequalities are increasing throughout the world. The next. How to respond to all these challenges. The next. First of all, we have to put emphasis on the life course. The next. And I think that this is encapsulated into this graph. If we talk about functional capacity, we want to keep our lives in the red line so that we increase our functional capacity, which of course is very low when we are born, in childhood and early adulthood and adolescence. It starts to increasing very fast, and then we reach a peak at about the age of 25, 30. You will see in 2 weeks' time the Olympic Games in Paris, and most of the champions will be in this age range 20 to 30. We will never be so fast, so strong. And gradually we start to decline. It's natural. This is called aging. What to avoid is the line. We reach the same peak, our age, and we start to decline very fast. And then we may hit the disability threshold prematurely. The good news is that you can, at any point, intervene and correct the decline so that we remain above the disability threshold for longer. We can do this individually, but we can also ask the public sector society at large to help us to maintain ourselves independent and to have independent lives until very old age. The next. And there is this mantra, the earlier we do that, the better. But it is never too late. The next. To respond to this, when I was director of the World Health Organization Department of Aging and Life course, we launched in 2002 the Active Aging Policy Framework. Next. It is still there in the WHO site. It's more than 20 years, influencing policies throughout the world. The next. Next. And we define active aging as the process of optimizing. Go back one, please. O anterior. We define as the process of optimizing the opportunities for health, lifelong learning, participation, and security in order to enhance quality of life as individuals age. Next, please. The next. It depends on determinants. I will not go into the details, but each of these bubbles, health and social services, behavioral determinants, personal, physical environments, the social environment, economic determinants, they all influence active aging individually within a context that not only they influence directly, but they are interlinked within a background of gender and culture, the next, which are the cross-cutting determinants of active aging. What is important in Shanghai may not be so important in São Paulo or Rio. So we have to look at the specific culture, but also the gender implications. Next, please. Next. We made a revision, my International Longevity Center, which is based in Rio, the next, so that we could bring new elements to this framework. Next. And you will find all this in our site, in English as well. But basically, we have these 4 pillars. It's aging, to do with health, lifelong learning, participation, and security, protection. The next, please. How would I translate this to the public? There are 4 capitals that are needed to be accumulated for aging well. First, next, please. We have health, the vital capital. The next, reminding everybody what WHO says in the Ottawa Charter for Health Promotion. Health is created within the context of everyday life, where individuals live, work, get entertainment, eat, move, love. That is where health is created. Failing that, we need health professionals that are well-trained in relation to aging, something that I am sorry to say is not happening in Brazil. Only 10% of our medical schools have a discipline called geriatric medicine. And what we need is that all health professionals, not only geriatricians, will learn everything about aging, because increasingly they will have to deal with older people, not children or pregnant women. The next, please. The second capital, and I should also say, which is so related to this symposium, the scope for non-communicable diseases prevention. It's not to do with aging. If you look at the accumulated risk for non-communicable diseases, 2 individuals at the beginning of life have more or less the same risk one individual a little higher than the other. But as the passage of aging, the risk will be exponentially higher for one person in relation to the other the same age. It's not to do with age per se, but the accumulated risk factors. It could be obesity, sedentary life, smoking, doing all sorts of behavior, but also not having medical checkup. That is what is going to increase the risk of one individual related to the other. The next, please. Second is lifelong learning. As The Economist, a very influential magazine from the United Kingdom, we need to learn how to learn from childhood into old age. The technological revolution is not going to give us any respite. We have aging, and alongside we have a revolution technology everybody needs to learn. The next. The social capital, which is so crucial. Next. We have to ask ourselves if do we know who is going to look after you when you may need to be cared for? And that's not necessarily in older age. We may have an accident and we may need care for the rest of our long life ahead of us. So it's critical to have the care system in order. The next. And of course, the financial, the economic capital. The next. And the mantra remains. The earlier we start to prepare ourselves to old age, the better. But it's never too late. The next. And we introduce some concepts such as resilience. Yes, we do have losses as we age. And it is important to have reserves in order to respond, to adapt, to endure, to grow based on these reserves that we can mobilize in order to solve the problems or at least minimize the challenges and the impact. The next. And all this, one example is loneliness, that a silence pandemic revealed by the pandemic of the COVID-19. How can we prepare ourselves knowing that we have more and more older people suffering from loneliness? The next. But all this is meaningless if we don't have a purpose of life. To cultivate a purpose of life, to know why we woke up, why you have come from China, to share your experience. Why are we all here early in the morning in order to make a difference to the world? I would have other slides, but I'm conscious about the time. I am so sorry that I'm not there at my dear academy with my dear peers and welcoming the Chinese delegation, but you will be in very good hands. I have invited as honorary member of the academy at the request of our president and dear colleague Maurício, two colleagues that have a lot of experience to share. First of all, Dr. Karla Giacomin, who is the Vice President of the International Longevity Center. She's based in Belo Horizonte. She's going to make her presentation also, like me, virtually. And then we will have Eberhart Portocarrero-Gross, who is a family doctor, works in one of the favelas, one of the slum areas in a very poor community, and it's a young guy that when I look at him, I have hope that the younger generation will respond to the challenges of this longevity revolution. I wish you all a very fruitful day. And again, regretting that I'm not presentially with you and I hand back to our dear President and to my colleague Maurício. Thank you very much. Muito obrigado.
Thank you very much, Professor Kalache, for your fantastic presentation. As usual, as you have seen, he's really an expert in this topic with a great experience, not only national, but international, and he helped us very much preparing the symposium. Well, we'll continue now with Professor Eberhart Portocarrero-Gross, as he has presented his physician, his work in one of our communities in Rio de Janeiro. He's a family doctor, and he has a unique experience in the anti-aging, in the base of our society, with the poor people, and he will show now his presentation. And I thank very much for your participation, Professor Eberhart.
I thank you, Dr. Maurício. Can you all hear me fine? Is this good? Okay. So first of all, I'd like to say I have no slides, as you back. I have no slides, as you can see, so please bear with me. We'll see what we can do, just talking to each other face to face, just directly. And so I'd like to start by thanking the invitation, thanking Professor Alexandre Kalache for his trust in inviting me, and for thanking the academics who are welcoming us here in the person of President Eliete Bouskela. It's really a pleasure to be here. I was actually here more than 15 years ago as a medical student to deliver a talk on physical examination and the importance of clinical thinking during the university years. So it's really nice to be here again after so long. And so just to introduce myself, I am, as Dr. Kalache and Dr. Maurício have said, a family doctor. I graduated in Escola Nacional, Escola de Medicina e Cirurgia, Medicine and Surgery School here in Rio de Janeiro. And I did my post-graduation, my residency training in family medicine in the National School of Public Health in Fiocruz, ENSP. And nowadays I work in primary healthcare in Rocinha, a favela in Rio, which many of you probably are aware of, both in direct care of patients and as a preceptor for residents. Also, I'm a focal point for primary healthcare for the International Longevity Center. And so that's from where I stand to speak here today to you. And as a declaration of conflicts of interest, I'd just like to say that if working in the public health system is a conflict of interest to talk about it, then I'm guilty of it. I work in SUS. I have done so for my whole professional life, and I'm really, really proud to do so. So that's, again, where I'm speaking from. But it is a fact that almost everything that will be said here today really only makes sense within a healthcare system. We'll be talking about, we'll be listening about prevention of lung cancer, biomarkers for diagnosis and prognosis, treatment of liver cancer, breast reconstruction after surgery. This entire arc, from prevention to rehabilitation, if we want them to be well applied, all these techniques, we need to ask ourselves, in which context are these techniques applied? Ideally, to borrow the key expression from the work of Dr. Daiming Fan, President of CACA, already quoted by Vice President Ying Wang, ideally, we should apply these techniques, all these techniques, in a holistic and integrative system, right? It won't make sense otherwise. We should think carefully about this word system. We need systemic thinking. We need to be able to think in terms of complexity, as Edgar Morin, the famous French philosopher, will say. That's the only way to develop the resilience Dr. Kalache was just saying will be needed in the future years to deal with the longevity revolution, to deal with the increasing cancer rates that will come along with it. We'll need to be able to adapt, and so we'll need systemic thinking. And so a system that takes into account the interdependent relations between the multiple biological, psychological, social aspects involved in each of the techniques that will be discussed here today. And between them, among them, how do they relate? We need to think about this. And actually, all I want to say here today is that the Brazilian public health system, SUS, it is very well equipped and can be even more well equipped to this holistic and integrative outlook on healthcare. Before our public health system, to give you a historical perspective, just 40 years ago, not long ago, in the mid-80s, Brazil still had a fragmented system, if we can call it system even. We didn't have a proposal for a real unification. We had scattered services here and there. Assistance was provided either by private services for those who could afford them, who could pay. A social security system for those formerly employed, which were not the majority. And good luck to everyone else. Those without money or formal employment, they just had to deal with diseases and illnesses as they came about without real support from the government and from the people who actually lived right next to them. And this is a special point I wanted to emphasize. It's not the government as an abstract entity, but it's actually taking care of each other. What were we doing then to those who needed it the most? A holistic and integrative system knows that the biological situation has an interdependent relationship with the social situation. For example, we know that the poorest are the ones who get sick the most, and therefore they are the ones who need health services the most. Leaving them on the margins of the health structure is a strong example of what the British doctor Julian Tudor-Hart called the inverse care law. In general, it means that those who need it least, those who need healthcare least, will receive more care. And those who need it more, who need it most, will receive the least care. So that's why it's the inverse care law. We'll give more to those who need less. We'll give less to those who need more. And as a corollary, he indicates that this is more intense the more the services are guided by market forces and not by an organized thought, not by a governmental thought. And so it is not difficult to see the truth of these statements, is it? There's no shortage of studies in regard to knowing this. Then what do? If we really think about it, if we really think that the point is to give adequate care to those who need it, not less, not more, but what is needed to each person. What do? Well, in Brazil, we made a choice. By the end of the 80s, as we were living a long period of dictatorship in Brazil, this very socially unequal country made a choice. We wrote into our constitution that we would maintain through taxes, through general taxation, a health system that served everyone according to their needs in the various aspects that would be necessary. And these are actually the three main principles of our healthcare system. The ideas of universality first, meaning a healthcare system which will take care of everyone. It's universal. the principle of equity, giving according to the needs, giving more to those who need more, giving less to those who need less. So pretty basic bioethical principle, right? And integrality, or as some will call it, having a whole person perspective, articulating health promotion, disease prevention, diagnosis, treatment, rehabilitation, all the things we'll talk about here, right? So we have these three guiding principles: a system which is universal, which has equity, and which can take care integrally of the person who is in front of them. And so, hence the expression civilizational landmark or civilizatory project. It is a healthcare system, SUS, as an element in the construction of a civilization anchored in solidarity. That is, in the mature understanding that everyone takes care of themselves, each man for himself, does not build a country, does not build a healthy society. We have interdependent relationships with each other. If I see illness and hunger around me, it makes me sick too. Doesn't it make you sick to see a poor person in the street, to see someone who's ill and does not have help, does not have proper treatment? It makes us sick to see it because we depend on each other, because empathy is a basic human trait. We'll look at someone who's suffering and we'll suffer a bit ourselves. And even if I pretend not to see, it will impact me. Even if I try to isolate myself, it will impact me. If my compatriot, on the other hand, is healthier, somehow I am healthier too. And in fact, today, approximately 70% of the Brazilian population uses SUS, uses this healthcare system exclusively, uses the public healthcare system exclusively. This means about 150 million people. It's quite a lot. That's what they use for their healthcare. And 30%, the minority, will have private coverage, but they will also use SUS. They will also use the public health system because they will use it for transplants, will use it for high-cost medication, such as cancer medication. They will use it for emergency care, vaccines, HIV treatments, and many others. Of course, that is not to say that there are not difficulties, there are not hardships. From the first moment, there were. We often forget the obvious, that we think, and then we think that we are beings isolated from each other. We forget these basic principles of interdependence, which guide holistic and integrative care. We just forget about it. And so ideas arise that maybe the public health system should be reserved for those who do not have the money to pay for private services, which, let's say, are mostly not organized as a system in itself. And then, starting from that, we forget that a system which is designed for the poor is going to be a poor system. There's going to be no investment, there's going to be no thought about it as it would have if it was, and it should be, designed for everyone, because then everyone will be engaged in making it better. If it is designed only for the poor, it will only be the poor trying to defend themselves and to defend the healthcare system. And of course, they will not have as much power as if all the society was united in this endeavor. And then underfunding will follow. We also tend to forget that health, education, housing, leisure, these are all connected, and therefore they must be thought of and must be built together. And ideas start to emerge that then maybe the best thing would be for the state just to pay for the system and let other entities to organize the system. But they will not be able to organize it properly, will they? Because they are not taking care of the other aspects would constitute health in the broadest sense. then the weakening of the state and the system and privatization will follow, if you think like that. There's no shortage of studies and evidence that solid public health systems will reduce mortality for everyone with a better cost-benefit ratio. The United States of America, with its very high technology, with robotic surgery, with all the most expensive treatments, is actually, but with its emphasis on the individual instead of on the society, is actually the developed country that spends the most in health with the worst results per dollar invested. So it's not a smart decision, is it? If we really think about it, from many perspectives, from the financial perspective, from the social perspective, from the moral perspective, what would be the right way to go? Sometimes we forget what it is, but we should make an effort to remember it. Of course, we are confused and fearful for ourselves, and so sometimes we tend to retract and try to take care of ourselves first. But we should not forget, we depend on each other. So taking care of myself and not taking care of the other is leaving me only half taken care of, so to speak. Dr. Daiming Fan, in a 2014 article, in which he presents holistic integrative medicine, he will present 9 harmful effects that the fragmented vision that plagues medicine and in fact society as a whole. He will list these 9 effects and explain them one by one and offer solutions. By reading his article, I was really happy to see that for all of them, for all 9 problems, a robust public health system, especially anchored in a strong primary health care, guided by the principles of family and community medicine, it will work as an antidote for those problems. I will quote a passage from Dr. Daiming Fan. He says, and I quote, "The specialization of modern medicine turns the linear thinking pattern of one disease, one gene, one pathogen, one treatment into the mainstream of medical development. This linear longitudinal treatment is not enough. Instead, we need a comprehensive point, line, surface, body, prevention and treatment, taking pathogen, disease, population, and society into consideration. Therefore, preventive medicine itself needs to be integrated not only with the disciplines in the preventive medicine field, such as epidemiology and labor and environmental health, but also the disciplines in preclinical medicine, clinical medicine, and even social medicine." End of quote. And this is, in fact, our public health system proposal, the SUS proposal. That's exactly it. To consider health in a broad, holistic, and ultimately realistic sense. To remember that these various entities that we should never have believed that are truly separate are by nature integrated. What am I talking about? I'm talking about not forgetting that they're actually integrated, the biological and the social, the environmental and the psychic, the individual and the population, self and other. Acting in accordance with these principles means acting fundamentally with solidarity, a value so dear to everyday medical practice when we're in front of sick persons, in face of a patient, but also a value which is so dear to our entire Brazilian healthcare system. We should give this some thought, I think, and engage in the maintenance and in the growth of such a smart and such a moral and ethical system. Thank you so much for your attention. Obrigado. 谢谢你.
Thank you, Professor Eberhart, for his very good presentation. As we have discussed yesterday, Brazil, we have a universal system that covers all the population, at least theoretically, and as he said, 70% of the population really uses the only system of health coverage. And this experience of Professor Eberhart that's working directly with this population, it was very rich for all of us. I thank you very much for your contribution and your fantastic experience. Thank you very much. Well, we'll continue now with Professor Karla Giacomin. She's Vice President and Technical Director of this International Institute for Aging. That's Professor Kalache is also. She is a specialist in geriatric and gerontology at the University of Louis Pasteur in Strasbourg, Master in Health, Public Health by the Federal University of Minas Gerais. She has a PhD in science by the Fundação Oswaldo Cruz, Instituto René Rachou, and she's professor of medical anthropology and public health policies for aging and the post-graduation. She developed many research in areas of anthropology, functionality care, integrative, and all the research. And she works in Belo Horizonte, and now she will participate in remote. I ask Professor Karla Giacomin, you have the floor for your presentation. Thank you very much.
Thank you. Thank you very much for this invitation. I'm very proud to be here, and I would like to thank to the Chinese committee. I am very proud and very interested about these themes. So I ask to share my presentation, but I will talk in Portuguese. Just a minute. Ok. A minha questão seria qual é o papel da academia diante da condição em que estamos. Nós sabemos que todos queremos envelhecer de uma forma ativa, saudável, incluída na comunidade, na sociedade, mas nós temos um país radicalmente marcado por uma desigualdade social que diferencia muito a forma como as pessoas envelhecem, né, nas comunidades mais carentes ou nas comunidades mais abastadas. A Organização Mundial de Saúde definiu que estamos na década do envelhecimento saudável e este movimento intenciona estimular para que todas as entidades, a sociedade, as universidades, o mercado, o poder público, que todos trabalhemos na mesma direção de promoção do envelhecimento saudável. E é muito salutar que, pela primeira vez, o cuidado também aparece como um dos temas definidos para o envelhecimento saudável. O professor Kalache é um pioneiro e tudo que ele disse até agora na sua fala anterior reforça a necessidade de nós mudarmos a forma como pensamos, sentimos e agimos com relação ao envelhecimento e à idade, e de garantir que as comunidades, né, promovam cada vez mais as capacidades das pessoas idosas e que no sistema de saúde haja uma entrega de cuidados integrados da atenção primária, centrados na pessoa e adequados à pessoa idosa. E bem como que o quarto pilar da década diz respeito à entrega de cuidados de longa duração. Bom, será que o nosso ensino de medicina tem acompanhado essa necessidade ou essa revolução da longevidade, como diz o professor Kalache? Esses dados da Associação Brasileira de Ensino Médico, que foram retirados no site da ABEM ontem, aponta que nós já temos mais de 300 escolas médicas e temos mais de 7.200 estudantes de medicina acadêmicos com 506 residentes e pós-graduandos. E quando a gente avalia nas diretrizes curriculares nacional médica a respeito do perfil do graduado em medicina, é um perfil que se pretende generalista, humanista, respaldado na ética, capacitado para atuação em diferentes níveis de atenção, para a promoção da saúde, para a prevenção de doenças, para a recuperação, para a reabilitação, considerando os determinantes sociais do processo de saúde e doença. Então, este profissional ele deve ser capaz de utilizar o seu conhecimento para promover mudanças na sociedade para além do campo clínico e científico. E esses conhecimentos, habilidades e atitudes devem ser desenvolvidas no decorrer da graduação, tanto em nível individual quanto coletivo, com um senso de responsabilidade social. Então, a gente vai convidar a uma reflexão sobre a teoria e a prática. É importante dizer que a demanda por uma qualificação médica ela está presente desde 1994 na Política Nacional do Idoso, onde se estabelecem diretrizes para a qualificação da educação permanente em saúde da pessoa idosa, onde se conclama a inclusão nos currículos escolares de disciplinas que abordem todo o processo do envelhecimento, da senescência, valorizando a pessoa idosa, né, com divulgação da promoção da saúde em todas as faixas etárias. Para isso, se prevê a adequação de currículos, metodologia, material didático, sempre buscando um atendimento holístico. E ainda o incentivo à criação de centros colaboradores de geriatria e gerontologia nas instituições de ensino superior que atuem de forma integrada com o Sistema Único de Saúde, né? E por isso também a discussão e a readequação de currículos e programas de ensino nas instituições de ensino superior abertas para a terceira idade. O que nós queremos dizer com isso é que o ensino médico ele deve englobar e fazer parte de todo um sistema voltado para o ensino que diz respeito ao envelhecimento como parte da condição humana, como parte de uma etapa do curso da vida. O Estatuto da Pessoa Idosa reforça a necessidade de inserção de conteúdos voltados para o processo de envelhecimento em todos os diversos níveis de ensino formal. E reforça também a existência de serviços geriátricos e gerontológicos em ambulatórios, unidades geriátricas de referência, atendimento domiciliar, reabilitação, integrados com o SUS. As diretrizes da Política Nacional de Saúde da Pessoa Idosa, no âmbito do SUS, prevêem o provimento de recursos capazes de assegurar qualidade da atenção à saúde da pessoa idosa, formação e educação permanente dos profissionais de saúde do SUS na área de saúde da pessoa idosa, apoio ao desenvolvimento de estudos e pesquisas. Então, na prática, é importante que, para o cuidado a uma população idosa, conhecimentos e aplicação de conceitos estejam sendo utilizados desde a promoção, prevenção, suporte social, cuidado integral, até a paliação. Porém, os conceitos específicos da geriatria e da gerontologia, como as síndromes geriátricas, as incontinências, a imobilidade, a instabilidade, as incapacidades cognitiva, a iatrogenia, conceitos referentes à reabilitação, fragilidade, conceitos referentes à independência e autonomia ainda não constam da maior parte dos conteúdos de graduação médica, nem das ciências da saúde. Portanto, o processo educativo estratégico para lidar com o envelhecimento populacional deveria compreender os níveis educacionais anteriores à graduação, mas também avançar para a educação permanente continuada, com foco no trabalho interdisciplinar e em equipe. Então, como que a gente quer que a medicina e que a academia participe da formação médica? Integrando escolas médicas e serviços públicos de saúde, aproximando os estudantes com a realidade de saúde do país. Vocês sabem que as escolas médicas são extremamente caras, a gente está falando de cerca de R$12 mil por mês de mensalidade. Isso não é a realidade da maior parte da população brasileira, né? E as escolas médicas públicas, elas também não conseguem suprir toda a demanda por formação voltada para o envelhecimento. Além disso, as diretrizes curriculares nacionais médicas do curso de graduação em medicina, que foram revistas em 2014 e em 2022 incluíram a necessidade de formação em cuidados paliativos na graduação médica, ele propõe, né, que esses conteúdos fundamentais incluam desde o diagnóstico, prognóstico, conduta terapêutica nas doenças que acometem o ser humano ao longo da vida, né, até a promoção de saúde e dos processos fisiológicos dos seres humanos. Então, esses conteúdos deveriam trabalhar com todo o processo saúde e doença do cidadão, da família e da comunidade, né, proporcionando, então, essa integralidade do cuidar em medicina. Bom, na prática, nas escolas médicas, o programa curricular inclui ciclos de pediatria, ginecologia, cirurgia e clínica geral. Mas as mudanças curriculares e a sua implantação são lentas e não têm acompanhado a velocidade do envelhecimento da população brasileira. E alguns motivos têm sido alegados para essa dificuldade em atender às novas demandas. A falta de profissionais capacitados para o ensino, quer dizer, faltam professores para ensinar essa temática, várias questões burocráticas que dizem respeito às mudanças curriculares. Nós somos capazes de reconhecer também o idadismo, ou seja, a desvalorização de uma formação voltada para a pessoa idosa a partir de uma desvalorização da própria pessoa idosa na sociedade, e a ideia de que as pessoas idosas não necessitam de profissionais treinados para o seu atendimento. Porém, os próprios médicos falam que a população que mais procura médico é a população idosa, exatamente por ser acometida por doenças crônicas ou outras doenças. Mas o idoso muitas vezes é deixado de lado porque não tem mais funcionalidade, não serve mais para nada. Então, eu acho que é muito deixado de lado, por isso tem que ter importância da gente voltar a atenção para se formar, lembrando que da mesma forma que a gente se preocupa com a criança e com o adulto, tem que se preocupar com o idoso. Essa é uma fala de um profissional médico a respeito de como deveria ser a sua formação. Os profissionais recém-egressos da Faculdade de Medicina não dispõem, portanto, de competências mínimas para atuar na atenção à saúde das pessoas idosas, têm dificuldades para identificar as situações de risco para fragilização, de risco de perda de autonomia e de independência, têm dificuldades de utilizar medidas preventivas e de suporte clínico e de trabalhar em equipe. Nós sabemos que a gerontologia e a geriatria são ciências absolutamente interdisciplinares e intersetoriais. Como que os médicos percebem a necessidade da formação? Totalmente importante. A população está envelhecendo, a pirâmide tende a se inverter, essa problemática, né, vai chegar para os futuros médicos que vão pegar no dia a dia, na prática, nos postos de saúde, nas emergências, nas especialidades, né? Tem que ser uma disciplina obrigatória, porque cada vez mais vai ter um percentual maior de idosos. A população está envelhecendo, então você atende uma demanda muito alta de idosos. O ensino é importante porque vai atender uma demanda muito alta de pacientes. Quer dizer, os médicos estão convencidos disso. Por que, então, o sistema não está convencido disso? Nós temos financiamento de residências médicas. Apenas 3% das prefeituras financiam, 40% vem do Ministério da Saúde, 21% do Ministério da Educação, hospitais 17% e governos estaduais 19%, com uma distribuição bastante desigual. 56% dos médicos residentes estão na região sudeste do país, 17% na região nordeste, 16% no sul, 7% no centro-oeste e no norte 3%. Deveria haver um médico geriatra para cada 1.000 habitantes, o que supõe-se 310 mil médicos geriatras atuantes no Brasil. Mas em 2023, nós tínhamos menos de 3.000 médicos geriatras no Brasil. E desses médicos, 62% mulheres, com idade média em torno de 45 anos. Recentemente, o que se observou? Dos 41.800 residentes, apenas 0,7% optaram por fazer geriatria. Esses residentes são os potenciais preceptores, os potenciais educadores, professores, que poderiam, então, ser incorporados aos currículos, às faculdades, para ensinar esse cuidado. Você vê que é muito pouco atraente o ensino da geriatria. Só que, de acordo com a nossa lei que rege o SUS, a saúde é um direito fundamental, o Estado deveria ser provedor, o SUS deveria atuar em redes. 80% da população idosa brasileira depende exclusivamente do SUS. Isso precisa ser considerado, porque quando a gente retoma a história do currículo nacional médico, que estava previsto desde a Constituição Federal, no seu artigo 200, que fala que o SUS regulará a formação médica, na Lei 8080 e depois nas próprias diretrizes curriculares que se fizeram, né, presentes, essa regulação da formação profissional está presente a partir do SUS. E o SUS responde por 80% da atenção à pessoa idosa. A Lei 8080 fala que a União, os estados, o Distrito Federal e os municípios exercerão como atribuição participar na formulação e na execução da formação da política de formação e desenvolvimento de recursos humanos. Isso também está presente em todas as conferências nacionais de saúde. Todas elas, até a última, falam da necessidade de capacitação, de educação continuada, de educação permanente, de mudanças na graduação, de reformas no currículos, de formação de especialistas de acordo com a necessidade do SUS. A primeira diretriz curricular nacional de medicina, que acontece em 2001, ela ainda parte de um modelo biomédico hegemônico. A Diretriz Curricular Nacional de 2014, ela trabalha com 3 grandes eixos: atenção à saúde, gestão em saúde, educação em saúde. E daqui para frente, nós pretendemos uma expansão da cobertura assistencial no SUS para prover e fixar profissionais de saúde, investindo no processo de formação médica e educação permanente, a partir de um modelo assistencial centrado no cuidado em saúde. Se o SUS é parte da decisão que regula a formação médica, quais bases orientam a atuação do SUS? Não faltam pesquisas da nossa sociedade para dizer quais são as demandas reconhecidas da população idosa. O que falta para identificar a população idosa como um público prioritário? Nós temos dados da Pesquisa Nacional de Saúde, da Pesquisa Nacional por Amostra de Domicílio, do Elce Brasil, do Vigitel, que apontam a população idosa como uma população que demanda cuidados diferenciados. O que a academia precisa responder? Se isso é fato, por que em todo o território nacional só existem 35 programas de residência médica que atraem apenas 0,7% dos residentes? A pessoa idosa ainda é identificada apenas pela presença de doenças. O gestor público não recebe incentivos para cuidar da pessoa idosa. E por causa dessas condições, toda a sociedade sofre com a falta de cuidados voltados para o envelhecimento no curso da vida. Então, é importante que a inclusão do processo de envelhecimento como curso de vida em todos os seus aspectos no currículo de graduação seja, de fato, uma prioridade. Que seja apresentado a todo aluno de graduação os princípios da prática geriátrica. Lembrando que mudanças propostas para a educação médica só afetarão os serviços após 10 a 15 anos da sua implementação. Então, nós não podemos perder tempo. As demandas relacionadas à pessoa idosa não serão supridas, portanto, em curto prazo. Por isso, é primordial viabilizar a difusão da noção de envelhecimento humano como um processo natural de todos os seres humanos e como uma mola propulsora para esta transformação que se encontra nos espaços acadêmicos. Caso contrário, nós vamos continuar como a política do avestruz, com a cabeça na areia, imaginando que alguém vai solucionar essa questão para nós. Portanto, é fundamental fomentar a criação de centros de pesquisa sobre envelhecimento integrados aos serviços de saúde. Não temos tempo a perder. Até quando, né? O SUS precisa cuidar das pessoas idosas, e isso inclui acesso a cuidados gerontológicos. Isso passa por investir na educação permanente e em competências da rede SUS para o cuidado da população idosa. Incluir os diferentes cenários de cuidado na formação médica das residências e multiprofissionais do SUS, inclusive os cuidados de longa duração em instituições de longa permanência. participar ativamente da construção da Política Nacional de Cuidados que está em gestação, fortalecendo o cuidado na comunidade, especialmente aquele que apoia a família. E exigir do Legislativo a ratificação da Convenção Internacional dos Direitos da Pessoa Idosa. A qualificação e a formação médica não acompanham o envelhecimento populacional brasileiro. Portanto, é preciso agir agora. Muito obrigada.
Thank you very much, Professor Karla Giacomin, for this very important topic. I think we are discussing now this in the Academy, Professor Kalache, and we have a program of young physicians, and we will start to have now seminars, especially for this topic of aging, and try to stimulate them for this participation. But I think our medical schools should be open for these ideas, and I hope that more and more, and we will perhaps listen later, how is the Chinese experience about this? How about the medical schools in China are including or not the question of aging in the curriculum? We will have the opportunity to discuss later. Thank you, Professor Karla. Well, we will continue our program. I invite now our academician, Fernanda Tovar Moll. She's a researcher, and she will talk about blood and imaging biomarkers of aging. And she has a huge experience in this topic, and will present now some biomarkers that you can use for evaluation and how to prepare for this period of life. Thank you, Fernanda, for accepting our invitation.
Thank you so much. Thank you, everybody. I'd like to thank Professor Maurício Magalhães for the invitation to be here. I'd like also to thank Professor Eliete Bouskela, the President of the National Academy of Medicine, and also thank Professor Wang and the whole Chinese delegation to be here. So I will try to talk a little bit about blood and imaging biomarkers of aging. It was an honor to hear the previous presentation, and I think that I don't need to go over again the importance of studying aging, especially in the next years. And this is actually not only a problem or a question, actually an issue for one country, but the whole world. And there are multiple ways to really investigate biomarkers in different systems and organs. And when we are talking about biomarkers, we are talking about actually multiple ways to measure signs of aging. And I will talk more about brain biomarkers of aging and what we are seeing, of course, while we are getting older, we actually are losing a little bit of our homeostasis. We also lose the mechanisms of compensation and also resiliency. These actually are followed or integrated to a lot of factors that are related to pathological change and that we can measure while we are actually measuring functions like losing memory or some other skills, but also morphologically changes. So in brain volume, we know that we have a shrink of our brain, we have a loss of gray matter and also white matter. And nowadays, there are a lot of ways to really measure that in a quantitative way. So these are very good frameworks from our Chinese colleagues that just was recently published and shows the evidence that we can have for different aging biomarkers. And I'd like to call the attention for the two main aspects that I'm covering here in this presentation. So for imaging biomarkers, we have actually a good, already a good evidence for MRI measures or metrics, and also measures of white matter also changes. But also here, the fluid biomarkers, that's very recent. So we now can actually measure in our blood signs of change in our brain. While before, this was only possible to measure with the CSF. As the techniques get more and more advanced, we can really measure even really little quantities that actually represents different biomarkers of the aging of our brain. And of course, when we're thinking about aging of our brain, we can have like a health aging, but of course, looking for different biomarkers, this can also help us to understand other pathological changes that can be happening, like in dementia. And the whole world have been looking for biomarkers that we can really identify patients that will develop dementia with different biomarkers. So the CSF biomarkers, some imaging biomarkers is in the literature for many, many years. But of course, the new advanced ones, and probably the most actually early change that we need to identify will really make the difference in terms of intervention, prevention, or guide any different therapeutical approach. So blood and also advanced image biomarkers is something that has been now having been more and more research for many, many centers. And I will try to show a little bit of our work. So we have been trying to follow those biomarkers at IDOR Memory Clinic Initiative. IDOR is a not-for-profit private institute here in Brazil. And more or less about 12 years ago, we started a cohort where we follow patients and subjects from different ages. And then we have been trying to measure, like in platforms, like a multidisciplinary platforms, where we have different clinical exams, neuropsychological tests, different types of MRIs, structural and also advanced ones. And we also collect samples of CSF and blood biomarkers. And actually, with that, we can also add different techniques as the new advanced ones are available for us. And this is also applied to different pathologies, like the same platform, the same ways that we are investigating biomarkers can be applied to other disorders, and that they have a lot of relationship between neurological and also psychiatric diseases. And of course, following through time is a way to really try to understand the early markers that can predict dementia and other types of neuropsychological disorders. So here just an example of the different tests that we perform. And we have been following different biomarkers in terms of imaging, the most quantitative ones, and also the more classical ones. Some of them are already available to the clinic. So nowadays we can measure the volume of the gray matter of our patients. We can actually plot that as we have in a curve that can predict where it is. But also with the samples here, we can see that the volume of our hippocampus, they really shrink over the years. But when we compare health subjects that are here in green with the curve of shrink of Alzheimer's patients, or also patients with mild cognitive impairment, they actually shrink in a more importantly, and then we can also discriminate them. But those techniques can only measure a little bit of our biomarkers in terms of imaging. And the new advanced techniques, especially the diffusion tensor imaging, this is this colorful picture that I just showed here, actually is measuring the movement of water molecules in the white matter, and can actually measure in a very quantitative way how is the microstructure change of the white matter. And with those techniques, we can actually predict even earlier and differentiate different types of dementia. So this is just an example where we have here in this yellow and red imaging is the white matter that's actually decreased in terms of microstructure in a type of dimension that's the cortical basal degeneration, compared to actually where we have here in blue and green is a frontal temporal dimension. As we can see, the frontal temporal dimension, the frontal lobe is much more affected than the other one, what actually correlates with the symptoms of the patient. And with those techniques, we can even investigate like mild change in patients. For example, narrative impairment has been appointed as one marker for Alzheimer's disorder, but even in early, like pre-dementia patients with mild MCI, here we show that they have actually change in the narrative impairment, but also those correlates with change in the brain and also with the CSF biomarkers. And changing the subjects in terms of the blood, how all these biomarkers correlate. This is, CMOA is a single molecular array. It's a very new technique and has pointed to one of the most promising tools to really understand biomarkers of aging and also in different neurological and psychiatric disorders. This is a technique that can also is a low cost compared to the other ones, so can also help the universalization of those measurements like that. And I would like to call the attention to some of them here, like the neurofilament light chain, and also other markers of Alzheimer's, like tau and all the other ones. And even FDA has already approved the measurement of the serum neurofilament light chain to actually predict multiple sclerosis deaths, and also to predict medication like response, so therapeutical response. And also in traumatic brain injury, the levels or the elevated levels of serum neurofilament can also show that predict patients to go lower in terms of actually degeneration. So it's a promising tool for dementia and aging is pointed to also be changed. So here is the validation in our cohort. So as we have the blood samples of the patients and the volunteers, we actually see that the increase of neurofilament during the years of age. Here in red, we have the cutoff of the Mayo Clinic, and here in blue, the cutoff of IDOR cohort. So it's pretty compatible, and most importantly, when we compare the controls, the rates of the neurofilament in the blood of the controls compared to the patients with dementia, we see that actually dementia patients has higher neurofilament than compared to controls. So, and also when we look at different types of dementia, we can also see here that controls have lower neurofilament compared to different types of dementia, including Alzheimer's patients, also Levy and other types of patients. And also GFAP, that's another biomarker that can also be measured in the brain. So both neurofilament and GFAP can be measured. Neurofilament is more related to neuron degeneration, and GFAP is also a marker of inflammation. And we see that is also elevated in patients with dementia compared to controls. And here is the sensitivity and the specificity. But most importantly, as I said before, as we follow those patients over a year, we actually got a couple of patients that we could discriminate that some of them have converted to dementia and others not. So here are the results of 2 years earlier that they have converted or not to dementia. And I'd like to call the attention to this graph here. So the patients that didn't convert to dementia compared to the one that converted to dementia after 2 years of this measurement in the blood had already higher levels of tau and also neurofilament in the blood. So the higher levels could predict in the blood that those subjects would develop dementia 2 years later. But of course, we know that dementia and Alzheimer's and other types of dementias is a multi-factor that is related to genetic risks, but also lifestyle and all the things. And another thing that we can look for biomarkers that actually will help us to diagnose, but also we can look to biomarkers that can also help us to predict to go to dementia or other types of neurodegenerative disorders. And one of the things that we know that help us to have a health aging of our brain is exercise. And why exercise can do that, we don't know yet all the answers, but there's this type of molecules that are called exercines. One of them is the irisin, is known to be produced by the muscles and also regulated, regulates metabolic and also cardiovascular health. But also was pointed that it can increase BDNF in the brain, and also in models of Alzheimer's could also prevent memory deficit. And with this same cohort at IDOR, we could show for the first time that actual irisin is also reduced in the CSF of patients with dementia compared to control. So it seems that irisin helps the brain to really prevent and exercise. This could be one of the explanations that's why exercise is good for health. Another thing that's very important to correlate is the relationship between inflammation in general and also neurodegenerative disorders. And there is a lot of evidence from different molecules that when the inflammation is increased, this also triggers different mechanisms of neurodegenerative disorders. Here is another example. We have been studying this protein, this molecule. It's a lipid-based molecule. It's called lipoxin A4. And actually, it was pointed that the lipoxin A4 is an anti-inflammatory, has an anti-inflammatory role in our system, including the brain. And as we can see here, with age, the lipoxin A4 decreases in our CSF. And also when we compare patients that has Alzheimer's disorders with controls, lipoxin is also even more decreased in patients that has Alzheimer's compared to controls. So it's another evidence that anti-inflammatory molecules can help us to have a better health aging of our brain. And in the last 5 minutes of my talk, I was trying to correlate those inflammatory triggers with neurodegeneration, but also pointed something that happens, and I think that everybody studied COVID-19 in the past years. And as soon as the pandemic started, we called the attention to also pay attention to the brain. And of course, this was a systemic disorder, and the lung was the most affected in the beginning. But with that, what we were trying to understand is that maybe the whole cascade, the inflammatory cascade, could even trigger neurodegenerative symptoms maybe in the future. So with this concept, we also we recruited patients with acute COVID-19, and we investigated neurological manifestations in the acute phase, but most importantly, after they were discharged from the hospitals, they did the same battery, the same multi-platform that we did for Alzheimer's patients. And of course, neurological manifestation was not the majority of the patients. Only a few had like main manifestations, starting with neurological manifestations. We had 45 patients that actually opened the whole systems with neurological manifestations. Here is one example, a patient that didn't have any lung manifestation but had encephalitis. And with these 45 patients, we could actually investigate some inflammatory biomarkers also in the CSF. And we can see here that patients that had severe COVID-19 had higher evidence of interleukin-6 and also TNF-alpha in the CSF. And also, This correlated also with the main manifestations like inflammatory, systemic, and also the neuroimaging finding. But what we also try to investigate is maybe the relationship between those biomarkers with actually biomarkers of neurodegeneration. So inflammatory biomarkers we actually expected to have more in COVID patients, but what was also interesting is that the most severe patients had also biomarkers of Alzheimer's and neurodegeneration compared to the patients with Alzheimer's too. And later, we also recruited around 300 patients that had COVID and was in hospitals. They had mild and severe COVID with no neurological manifestations. So now these 300 patients that I will show the results, they didn't have any neurological manifestations in the acute phase of the COVID. And they were recruited after they were discharged from the hospital 6 months later, and then 1 year and 2 years later. And when they came back to do the same cognitive, neuroimaging, blood investigation, what we saw was that actually they had, the majority of it, actually around 70% of them had fatigue, but also they had change in cognitive, they had cognitive impairments more related to executive functions, but also memory impairments. And when we investigate those patients that had cognitive symptoms in the long COVID, and remember, they didn't have any neurological manifestations in the acute phase. When we look into the brain of those subjects, we see that all those areas that are here in red are areas with decreased white matter microstructure. So they had changes in the brain that were actually correlated with the manifestations. And here, with this last slide, I will try to link all of those. So we had that post-COVID case presented global cognition, memory, and also executive functions deficit. And with a framework that actually is a causality framework that we did in terms of a statistical treatment, we see that inflammations in the blood, more linked to TNF-alpha, also interleukin-6, that were actually increased the patients, were related to the change in the MRI and were actually also responsible for the memory and executive impairment of those subjects. So with this last slide, I try to correlate both things, that we can measure biomarkers of inflammation, neurodegeneration in the blood. This can be related to changes, morphological changes in the brain, and can be responsible for different symptoms, as it was here in this case with patients with long COVID that I just showed. And with that, I would like to thank the whole group. This is a very, of course, multidisciplinary work. And I would like to thank you all. Thank you very much.
Thank you, Fernanda, for the fantastic presentation and your effort to try to be in the time of 20 minutes. Thank you very much. I know your hard work to do this with so many information. Well, we now will start the second part of our presentation, that we will have our Chinese guests. And we will start now with Professor Caicun Zhou. Professor Caicun Zhou is President-elect of International Association of the Study of Lung Cancer, Chief Chair of the Society for Oncology Drug Clinical Research, CACA, and he's from Shanghai East Hospital, Tongji University. And he told me yesterday that they are now starting a new center. They expected to treat 36,000 new cases a year of lung cancer. It surely is the biggest international experience. And I'm sure Professor Caicun Zhou can give a very nice presentation now. He will talk about anti-lung cancer strategies in China. Thank you, Professor Caicun, for coming. Thank you.
Dear chairs, colleagues, it's my great honor to be here to present some data from China lung cancer strategy in China. So at first, I'd like to give my thanks to the Dr. Costa for his a lot of help. That's why I could be here. Sorry, I didn't do. These are my disclosures. Lung cancer are top 1 cancer in China in terms of malignancy and mortality. So the amount 3 to 4 cancer-related deaths, 1 is lung cancer. What's more, we can see that incidence of lung cancer is still increasing in past several years. The increase is more famous, little bit higher in female compared with male. But the mortality of lung cancer start to decrease in past several years. The decrease of mortality is due to only diagnosis and precision treatment strategy. Recently, we just report over survival of lung cancer in China from 2008 to 2021. The standardized 5-year survival rate is about 29%, excellent result, which is comparable to that in the United States. Today, I try to discuss with you several strategies in anti-lung cancer. Let's start with prevention. I do think prevention is much more important and more cost-effective than the therapy. We have enough data to show that smoking of tobacco is associated with high risk of lung cancer. So with the decrease of the smoking, the prevalence, we do observe the decrease of lung cancer related deaths. Chinese government start to pay attention to tobacco control in China. In about 2005, we accept the Empower FCTC in China. After that, we enact a lot of laws and all regulation to inhibit or control public smoking in China, also increase the tax to tobacco. So I would say that the cigarette smoking become more and more expensive in China. I couldn't move. So what's wrong? This one? Okay. So this slide just shows the trend of smoking prevalence in China. You can see that the smoking prevalence is decreased from 26% to 20%. But we observe the special subgroup population that is in rural area born after 1990s. The smoking prevalence is a little bit increased. This population we should pay more attention to. So tobacco control become quite widely accepted in China. The people working in the public hospital, the factories, restaurant, and store accept idea of the public smoking inhibitions. We also observe that the active smoking prevalence decreased. More and more patients live in smoking-free area. The tobacco control is also one of great content for the Health China, the 2030, the blueprint. We set a target, so at 2030 and 2022, the target was met as to the smoking cessation as well as the smoking-free environment. Next, I'd like to discuss with you only diagnosis. We have 2 or 3 trials from the United States, from Europe, suggest that nodal CT screening could decrease the lung cancer-related deaths. There was one trial from China, which is a multi-center randomized study did show that ADCT lung cancer screening decreased lung cancer-related deaths, also all-cause the disease. So we start lung cancer screening program in China in 2005. The cancer screening program in rural area was started, about 7 years ahead of in the urban area. In 2009, the nodal CT was reimbursed for the screening of lung cancer. So the lung cancer screening, they become a kind of practice. The practice is more often observed in the eastern part of China, but not in the west part of China. Through the screening, we find so many early stage of lung cancer, about 50 to 60% stage 1 lung cancer, compared with the hospital find lung cancer only about 7%. That's our data. We found that the female, the ex-smokers, and the patient with chronic lung disease tend to accept uptake of the nodal CT of the screening of lung cancer. So we also change the screening profile. We know the nodal CT screening could decrease the lung cancer-related disease, but we have several issues we have not settled. What's the risk population? What's the standard risk population for the lung cancer screening? We also know that the CT scan also increase risk of cancer. Can we use biomarker? Can we use radiomics, use breast omics, and AI to help us to do lung cancer screening? So AI was first introduced into the lung cancer screening about 10 years ago. The first prospective study on the AI in lung cancer screening is ongoing. We need to wait for the result of the trials. The breast omics is important, the tool for the early screening of lung cancer in near futures. With detection of VOX in the echo breath, we found the VOX could be used for the early diagnosis of lung cancer, but we do not have any data of VOX in the screening of lung. We do have some meta-analysis made by China. We found that VOX has high sensitivity and specificity in early diagnosis of lung cancer. But up to now, we do not have any data in the lung cancer screening. Next, I'd like to discuss with you the precision medicine and the multidisciplinary therapy for lung cancer. We know that lung cancer is not one entity of disease. It could be further divided into several subsets according to oncogenic drivers. So molecular testing is as important as pathology. So we need testing, we need a test. In China, test of EGFR, ALK, and ROS1 is very, very high. Over 90% of patients have been tested for these 3 biomarkers. But for uncommon oncogenic drivers, such as RET, MET, HER2, and insectual, test rate is not so high, around 30% to 50%. Only 23% of our hospitals or institute has in-house test platform. We use a lot of commercial lab for testing of these biomarkers. That's kind of a problem. To do the test, we need a kind of collaboration between the different disciplines. This slide just shows our schema for diagnosis of lung cancer. Our speed is very fast. It only takes 4 or 5 days. We get test results, initiate the treatment to our patients. So there is good collaboration between us and intervention doctors, radiologists, molecular pathologists, and instructor. So we also know that multidisciplinary therapy is really important. The CACA, Chinese Anti-Cancer Association, set up the MDT Expert Committee. The committee initiates so many meetings to promote MDT ideas in China. The MDT is not only focused on the diagnosis and the therapy. Nowadays, we pay more attention to side effect of therapy and the follow-up of our patients, become a true the MDT program. We also have the patient navigation model in MDT. The model covers the early stage diagnosis to the later stage of therapy. So we put our effort in the early screening and early diagnosis in primary care, the clinics. We do a lot of MDT therapy in academic center. We also pay more attention to last stage of therapy in local hospitals. Telemedicine has been developed very quickly in China. China is huge, just like Brazil. Developed is not balanced. So we also use telemedicine to the local hospital for MDT. Nowadays, telemedicine is often used more and more in our hospitals. Next, I try to discuss with you improve access to novel therapy. Our government enacts so many laws and regulations to improve the pharmaceutical industry and also improve the access to the novel compounds. So in China, we have so many biotechs. Each biotech has several novel compounds. So clinical study has been increased greatly, about 300 compared with previous years. So we also set up National Reimbursement Drug List, NRDL. The drug in the NRDL will be reimbursed by medical insurance. The patient just pay about 10 to 20% of the compound in the NRDL. So we have so many clinical studies in China. So the increase of the clinical trial about 50% and 30% depend upon the area. I would say that we have more and more the study leaders. We also have more and more study leading institute in China. So last, I'd like to discuss with you the novel. So that we found so many booming of the pharmaceutical industries. So we have so many novel compounds. We have bispecifics, we have ADC. The cost of this compound decreased greatly, about 1/6 or 1/10 of the US compound. The access to this novel therapy increased greatly in past several years. This slide just shows the targeted therapy in China. The compound in white are only available in China. These compounds are produced by local industry, approved by our administration, available in our market. This slide just shows several important surgeon EGFR tyrosine kinase inhibitors. On the left side is AstraZeneca compound, where a FLORA study, the last 3 compounds are from China. You can see that this compound produced comparable efficacy in terms of progression-free survival, as well as progression over survival rate. In China, we also even have more in IO compound. The IO compound in the global only have about 5 or 10, but in China we have around 20 PD-1 or PD-L1 inhibitors. Our compound has even better efficacy compared with the original patent compound, nivolumab, pembrolizumab. This slide just shows one of my study, chemo. This is a randomized phase 3 trial comparing PD-1 inhibitor, domestic compound plus chemo versus placebo plus chemo. You can see that we got about 31% 5-year survival rate for advanced stage of lung cancer. That's just really excellent results. Last, I'd like to discuss with you the guidelines. We need guidelines to guide our therapy of lung cancer. China is big, is huge. The development is not balanced. We found so many inequalities for the diagnosis to access of therapy. Definitely, we need biomarkers. The CACA just initiate the guidelines for lung cancer. After the guideline is available, we have so many meetings to promote our guidelines. The CACA also set up the Cancer National Anti-Cancer Week. So we have so many activities try to increase the patient awareness in China. We also have the clubs for reading club, try to increase the cancer awareness in China. That's the guidelines. We have lung cancer guidelines, we have liver cancer guidelines, we have esophageal guidelines. After the guidelines available, we do have a lot of meetings just to prove the guidelines into our market. Besides the disease guideline, we also have technical guidelines. This slide just shows clinical study guidelines. It's technical guidelines. We prepare the guidelines, then we have the meeting to promote the guidelines across China. Because of effort, you can see that the outcome of lung cancer patients in advanced stage was increased greatly. About in chemo area, we only have 1 year survival rate, 2 years survival rate. That's chemo plus the carbo or plus 6. About 50 years ago, we have bevacizumab. The beef plus chemo could further improve 1 year survival rate and 2 year survival rate, but we do not have data on 5-year survival rate. Now we are in the era of targeted therapy, of immunotherapy. Chemo IO produce excellent over survival, the 2-year survival rate. Even nowadays, we have 5-year survival rate, that's 31%, much better than chemo alone. We have another study, Anicia. This study is comparing second-gen alectinib versus crizotinib in positive non-small cell lung cancer. We do found that 5-year survival rate is over the 6-7%. Excellent result, advanced stage of lung cancer. So we have made a great achievements in the control of lung cancer, but we also have so many challenges. We do not have enough doctors. We do not have enough resources. Development is not balanced, especially medical care development. So there are several priorities for cancer research in China. We should enhance public awareness. We should enhance the cancer prevention and early detection. We should stress MDT and precision therapy. We also need more and more innovative novel drug in our daily practice to treat lung cancer. I just summarize here, we need more and more anti-cancer strategy to treat lung cancer. Prevention is really important. We should control tobacco smoking. We need early diagnosis. The screening is right away to do the early diagnosis of lung cancer. We need precision medicine. We need guidelines. We also need novel compound. In this way, lung cancer could become a chronic disease. Let's work together to achieve this goal. That's my talk. Thank you very much for your kind attention.
Thank you, Professor Caicun for this comprehensive presentation, and it's impressive what China is doing in all the fields of cancer, and really congratulations for you and your team. Well, we'll continue now. I invite Professor Ning Zhang, who will talk about tumor heterogeneity and precision medicine in primary liver cancer. Professor Ning Zhang is Deputy Secretary General, China Anti-Cancer Association. He has his PhD training in Johns Hopkins and his postdoctorate in cancer research training in National Cancer Institute, United States. He has been there for 17 years, told me. He serves as a Boyer Distinguished Professor in Peking University and Vice President of Peking University International Cancer Institute, Vice Director of Peking University, Yunnan Bio International Medical Research Center, and the Chief Scientist of Yunnan Bio Group Company, Executive Director and Deputy Secretary General of China Anti-Cancer Association. Thank Professor Ning Zhang for coming. The word is yours, please.
Thank you. Thank you for the introduction by Dr. Maurício Costa. Thank you for the invitation by Dr. Wang Ying, and thank you for the Dr. Bouskela to preside this international symposium. It's really my great honor and privilege to present some of the studies in my laboratory in this symposium. The presentation of my talk will be the heterogeneity in the primary liver cancer and also some investigation in the precision medicine. Liver cancer is a big challenge in China. The incidence rate, China contribute to about 45% of incidence and the mortality worldwide. And if you look at the liver cancer, about 80% of the liver cancer are the hepatocellular carcinoma, and about 10% to 15% are so-called intracellular cholangiocarcinoma, which is treated mainly by the chemotherapy. And also there's about 1 to 5% is called combined type, HCC and ICC, which is a mystery in most of the case. And the current treatment, if the patients come at early stage of the disease, can be treated with resection or the transplantation. However, in China, most of patients, when they arrived in the hospital, they are at the late stage of the disease, so mainly has to be treated with the medicine. And this is showing one of the breakthrough in the HCC treatment is by the treatment with targeted therapy and also with the immune therapy, which significantly improved the PFS from 4 to 3 months to 6.8 months. So why the treatment is such a big problem? Only certain percentage of the patients respond to the immune therapy and the target therapy. It's mainly due to there's a tumor heterogeneity among the patients and inside the tumor patients. This concept was originally proposed by Dr. Huxley in 1958, and eventually been proved by the work by Charles Swanton in 2012. Our laboratory is interested to review the heterogeneity in primary liver cancer patients. We started our study on the 2012 and reported our first study in 2016, which showing in 10 patients the multi-lesion heterogeneity in the primary liver patients. As you can see that about 70% of the patients show the lower heterogeneity level, but among the 30% of patients showing quite high heterogeneity level and early metastasis. Right? Next, we look at this patient and we show in a particular case that this patient, if you look at the tumor, is showing both the hepatocellular carcinoma phenotype and the cholangiocarcinoma phenotype in one particular patient. And if we look at the mutation, they share about 80% of the mutation. It suggests that actually it's coming from one single origin. So why is this patient with a single origin of the tumor showing these two different phenotypes and how to treat it? So we treat it with targeted therapy and immune therapy as what we used in the HCC, or shall we treat it in the chemotherapy, which is using in the cholangiocarcinoma? So that's the question. I will come back to that question later. And then in the next study, we start to look at the heterogeneity in the liver patients at the single cell level, DNA level. At this time, there's two evolutionary models in the single cell evolution of the tumors in the patients, right? Mainly proposed by the Nicholas Levine in the MD Anderson, argues that in the triple negative breast cancer, it looks like at the single cell evolution level is a punctuated model. Basically argues that this punctuated model argues that actually all these mutations comes at a disastrous events, right? And not by a gradually accumulation of aneuploidy. So that has been proposed this is a classic paper in the Nicholas Levine, and also has been supported by several other studies. And when we look at the liver cancer, when we did the single cell sequencing of the liver cancer, we show a totally different pattern. It seems that there's both a punctuated element and a gradual evolution in the liver cancer. And so I named it as a dual phase copy number evolution model in the liver cancer. Eventually, actually, it has been demonstrated that this model has been applied for other cancers as well. All right. So further, we investigated the molecular biomarker for this heterogeneity and whether this heterogeneity correlate with the poor prognosis. Eventually, we come up with this gene called CAD. It's a gene, a critical gene in the pyrimidine synthesis pathway. And the overexpression of this gene or the loss of function of this gene correlates the heterogeneity of the liver cancer patients and also correlates with poor prognosis. So we have mentioned this particular phenotype heterogeneity, right? So this phenotype heterogeneity is in one patient. You can see both the phenotype of HCC and the phenotype of ICC. So the question is whether it's from two different tumors grow together or is one tumor grow into two different phenotypes. Shall we treat it as a HCC or shall we treat it with ICC? And whether we can find a biomarker for that. So we carry out this study and we look at this particular disease in 8 different hospitals. We look at about more than 20,000 of patient samples, and we carry out a multi-omic analysis of these samples, and eventually we find about 133 cases of combined type HCC and ICC. It's including the hospital from Japan, from Singapore, and from China as well. And we were the first person able to report the landscape, mutational landscape of this combined type HCC and ICC. One thing particular come to our attention is this high loss of function of TP53, both as a mutation loss of function and also as a copy number loss, right? Next, we also were able to have this molecular profiling of this disease, and we can see some of this profiling more similar to HCC. Probably we should treat it with HCC therapy first, or some of them more correlate to the ICC, probably it will be more accessible or more respond to the chemotherapy. Next, we want to find out among these 133 cases, what percentage of them are the, from the single clone, or what percentage come from different clones grow together. Actually, among these 133 cases, 131 actually from single clone. That means they share the most of the mutation. And apparently this from the one single origin, and then eventually they differentiated into two different kind of phenotype in one patient. So why is that? We found out this interesting biomarker, right? This biomarker is called a nesting. Nesting is actually a cytoskeleton protein which associated with the stemness of this cell and also the plasticity of these cells. Actually, the mechanistic study reveals that the loss of function of TP53 induces the high expression of this nesting. And this high expression of this nesting result in this plasticity and the stemness. So this group of cell, cancer cell, can either differentiate into the HCC or differentiate into ICC in one patient. So we come up with this nesting as a biomarker. So this paper eventually was published in the 2019. In 2021, they were able to collect about 20,000 samples across Europe and further validate that nesting is a biomarker for this combined type HCC and ICC. And also in our laboratory, we are developing the therapy specifically targeting nesting, which can give us a promising efficacy in the treatment. So the next story is about the microenvironment heterogeneity in the liver cancer. Everybody knows that Alexandre, right? They developed this immune therapy that actually benefit the cancer treatment. But only about 20 to 30% of liver cancer patients benefit from this treatment. And the reason of the different response due to the heterogeneity, probably due to the heterogeneity in the tumor environment. So we set out to study the microtumor environment in the Chinese patients. So we collect about 106 patient samples from these 116 patients, right? We collect their samples and then we establish 60 libraries. We carry out a single cell sequencing, right? Meanwhile, we established two mouse models, transgenic mouse model, to validate our discovery, right? So the sequencing data, we have about more than 1 million single cell data there, which account to about 70% of the single cell data you can see in the internet, in the PubMed or in the open source. So eventually we found out that this more than 1 million single cells, you can cluster it into 13 big groups and 86 clusters of cells. For example, we can have a lot of clusters of CD4 cells, a lot of clusters of CD8 cells, gamma delta T cells, dendritic cells, fibroblast cells, et cetera, right? And we can correlate, we can investigate and reveal how each group correlates to the prognosis or from the survival values of this group of patients. The next question is whether these 89 subclusters are evenly distributed among the 116 patients, or they have a tendency to distribute together. Some of the groups tend to distribute together. So we did this very simple mathematic analysis, find five different groups, 5 different microenvironment groups. And we named it as immune activated group, immune suppressive myeloid group, immune suppressive stromal group, or immune excluded groups, or immune residential group. And this we can further validate by the data from the TCGA. And this correlates the immune response of these liver cancer patients. And furthermore, I mean, all this calculation data from the single cell, we want to validate by the protein staining, right? So we eventually validate by the Codex staining, and also we evaluated by the special transcriptomic staining to showing that actually this thing exists in the patients, right? And at the same time, we found about more than 34,000 34,000 of the neutrophils. It has been known tumors has a lot of neutrophil in it, but nobody really studied the neutrophils function in the tumor. And we were able to show that actually there's a tumor-associated neutrophil clusters, right, in our patients. And we were able to show they're regulated by the different regulum, and also we can show their differentiation passage by the calculation. Furthermore, we found out two of this subgroup of neutrophil actually promotes the tumor growth. For example, one of this neutrophil subgroup called neutrophil 11, they express high level of CCL4. They attract macrophage to the tumor and then they induce them into the M2 macrophage. Another group of neutrophil which express high level of PD-L1, and this PD-L1 high expression of neutrophil in the large numbers inhibit the T-cell response. So we carry out these mechanistic studies by the transgenic mice. I will not bother you by the details, but eventually we found out that actually the neutrophil, tumor-associated neutrophil, are able to attract macrophage and then induce them into M2 macrophage, and also they are able to inhibit the CTL response by blocking the T-cell response, eventually to promote the tumor growth. And if we deplete the neutrophil by the LY6 in the mouse model, we were able to inhibit the tumor growth. So we argue that actually neutrophil therapy may be a supplement to the current therapy in the liver cancer. And this is a company founded by myself and with some of my colleagues. Based on these single cell studies, and we have attracted more than $200 million funding into that. And we have this first-in-class of drug actually targeted in the FAK, focal adhesion kinase, because we found out from the previous study published in the Nature that actually fibroblast is the major target, major problem in the, interfere with immune therapy. And this is showing that this compound in the ovary cancer showing amazing result. All these patients have been failed all the current treatment, but they are still showing a very promising result, response to our compound. And we hope to finish, and this has been approved by the FDA as a fast track drug, first in class, and also approved by the Chinese FDA. And we hope to wrap it up at the end of this year. And also Professor Zhou is helping us with the clinical trial as well. So the last story is that we have these patients, right? Only a certain percent of patient response to the treatment. Can we really provide a precision treatment? In other words, can we stratify these patients to tell them which patient should be used for which kind of treatment, right? So basically, we developed about close to 400 organoids from about 116 patients. Each patient will take a few points out to develop organoid, right? We were able to do the genetic analysis of all these 400 organoids, and also we can screen the drugs, the current treatment for the liver cancer with these 400 organoids. And by the machine learning technology, we were able to come up the first set of this molecular profiling, or we call it pharmacological profiling for the patients, to guide the patients to use the drug, right? Here we're showing that our organoid is good, a good organoid, thank Lord. And also we were able to show in the genetic mutations, the heterogeneity among the different sections of the organoids coming from the patients. And this genetic heterogeneity also showing correlates with the drug response heterogeneity among the patients. And then we screen them with all these 7 drugs has been used in the patient treatment in the clinic, and it's showing the different response. We show here, basic organoid we developed beautifully predict the patient's response. So that will be the first line of the precision medicine method treatment, right? To guide the treatment. And then we correlate this organoid result with the sequencing result. They come up with this molecular profile. And this thing can be used to predict which patients can use which kind of drug, right? Usually only 60% of the organoid can be developed. Some patients, we will not be able to have the organoid. We can use this molecular profiling to guide the patient treatment, right? And next, there's still 40% of patients not responding to all the treatment. With the calculation, we found out c-Jun is the major genes that's overexpression of c-Jun will correlate with the drug resistance. We knock out this gene in this 399 organoid, or we overexpress in the organoid, and we found that molecular pathways correlates, or molecular pathways contribute to drug resistance, and we develop new drugs strategies to treat these patients. So that concludes my presentation. We were able to show in the tumor heterogeneity at the single cell level, at the tissue level, and also at the phenotypical level. And also we were able to show the heterogeneity at the tumor microenvironment level. And this investigation leads us to the molecular biomarkers to stratify the patients and lead to the new drugs, new immune therapies to treat the liver patients. Thank you for your attention. And obrigado.
We just got to know that in China, we have now an audience of 2.2 million people.
Thank you very much, Professor Zhang, for his very nice presentation. We'll continue now. We'll have Professor Tianjin Song. We'll talk about conversion and neoadjuvant therapy for liver cancer. Professor Tianjin Song currently holds position of Director of Liver and Biliary Tumor Department of Tianjin Medical University, Executive Director of Liver Cancer Prevention and Treatment Research Center. He also serves as committee member for International Hepatopancreatic Biliary Association Research Committee, standing committee member of Chinese Medical Association Oncology, vice chairman of Liver and Gallbladder Professional Committee of European American Lung Association Physician. With 27 years of experience in liver and biliary tumor surgery, Professor Song specializes in radical surgery for liver, gallbladder, highly bile duct cancer, and other related conditions. Thank you, Professor, for coming. The floor is yours.
Thank you, Professor Costa, and dear President and the colleagues. And it's my great honor as a member of the CACA delegation to visit ANI. And this is for me the second time to be in Rio. And last time is 8 years ago. And I love this city. And there are not only the beautiful scenery and delicious food, but also has a good breathing, good friends. And there's a little modification of my topic today because of the time limited. So I just talk about the neoadjuvant therapy. And maybe next time in future, I will talk about the conventional therapy. And this is a picture we took the last time. And liver cancer is a very heavy tumor burden and cancer in China. And nearly 50% and the liver new cancer patient are origin from China. And the incidence rate ranked 5th, but the mortality rate ranked the 3rd. And in China, nearly 70% of people, when they are diagnosed, already in the intermediate and advanced stage. And if we follow the Western guideline, this part of patient would lose the chance of resection. So in China and the guideline, so we surgeon expand the resection indication. And we just, in Western guideline, only the patients in very early stage, they give the resection option. But in China, whatever intermediate and some advanced liver cancer, we also give the resection. But the result is not very good. This is a national survey and from China. Nearly 30,000 patients received the resection, but the 5-year survival only 20%. But why? Because high post-operative recurrence rate, and in 2 years, over 60% of the liver cancer patients even received operation, they will face to recurrence. And this is a basic research origin from China. They demonstrate that, and for liver cancer, more than 80% of people, even the tumor in very early stage, they have the potential ability to the spread and the metastasis. So resection is the old traditional and the treatment and option. But now in the new aging, we should change our strategy to treat liver cancer. New adjuvant therapy shows a promising result in several tumor areas, such as lung cancer and breast cancer, colorectal cancer, melanoma, and so on. But for liver cancer, this is a brand new area. But I'm very interested in this field. From 2020, I began to do some and pioneer exploration in new adjuvant for liver cancer. And this is we call the aim-guided and the treatment decision chart. We know and the different aim, we should take the different strategy, and the treatment intensity may be the different. What's the ideal new adjuvant therapy? I should follow the following principle. The treatment should be safety, and it should be efficiency, and it should be minimally invasive, and it should good cost efficiency. So before we carry out the new adjuvant therapy, so there's still some problems that should be solved. And which treatment is better? Systemic therapy or local therapy or combination? And how long should we treatment? So we should consider the following factors. The factor one is the overall response rate of this treatment. That means we could make a tumor shrink, make tumor and small, and make the resection easy. Also could eliminate the microscopic metastases. And by now, and the targeted therapy, immunotherapy, we could find the combination targeted therapy and immunotherapy has the best overall response rate. And the factor two is the disease stability rate. This is more important than ORR for the resectable cancer because, and this is ensure this part of patient could not become, because of the tumor progression and become resectable into the unresectable. So we can see all the combination regimen, the DCR over 80%. And the factor three is the liver-related grade 3 or above adverse event. This is avoid increase the risk of post-operative and liver failure and ensuring the safety of the surgery. And all the combination target and the IO therapy, regimen therapy, you can see the grade 3 liver-related and adverse event below 10%. The factor 4 is the PFS, TTR, and the median and the adverse event time. That determines the duration of a new adjuvant therapy. And we can see all the combination therapy, the PFS over 3 months, and the TTR over 3 months, and in 3 months. So maybe 2 or 3 months duration for new adjuvant therapy is safe and efficiency. So based on this principle and the factors, in our center, we conduct a series of new adjuvant therapy to answer this question. And the question 1, and the safety and the efficiency of a targeted and the IO combination regimen. And the first trial is the prospective single-arm phase 2 clinical trial. We combine the target therapy and the immunotherapy. And this combination is the only approved by Chinese FDA and the regimen. And 31 patients was enrolled. Most of them are in intermediate advanced stage. And among them, and finally 28 received the operation. And the 3 cases due to the tumor PD and cannot receive the operation. And the other 2, because of SAE, cannot receive the operation. Among the 26 patients, we can see the PCR and the PCR and MPR is 30%. The overall response rate is nearly 50%. So we conducted the other clinical trial. This clinical trial, we use lenvatinib plus PD-1. This combination is mostly used in China. And we also enrolled 30 patients, and also in the very intermediate and advanced stage patient. Among these 30 patients, finally 22 received operation. 5 people, because of the response is very good, the patient do want to receive the operation anymore. But there are still 3 patients because of tumor progression and lost the chance of operation. But this regimen we found more safer than the first one, because there is no grade 3 adverse event appears. And all the patient overall response rate much higher than the first one regimen. If we use the moderate RECIST criteria, we could find the OR is nearly 80%. So these 2 trials and give the answer for the question 1. Target and combined with immunotherapy as new adjuvant treatment option is safe and effective. So question 2 is a single immunotherapy regimen feasible? Because in Western country, they usually use immunotherapy as new adjuvant therapy for HCC. But in China, we usually use the target plus immunotherapy regimen. So we conduct another clinical trial. This trial, we use immunotherapy for 2 cycles. And we do the tumor response and the evaluation. If the tumor PR or decrease stable disease, we do the operation. If the tumor PD or increase the stable disease, we give the lenvatinib for another 2 cycles, and then re-evaluation, and then do the operation. By now, 41 patients was screened, and 36 patients was enrolled, and 33 patients and received the operation. But from the final result, we can find if we use the immunotherapy alone, the response rate and lower than the combination therapy. And if we use the M-RECIST criteria, the overall response rate only 30%. So this trial tell me current data shows that single immunotherapy is safe and reliable, but less effective than combination target and IO regimen. So the question 3, systemic or local treatment, how we choose. So we conduct a new trial. This trial, we use the randomized clinical trial, and the patient was randomized systemic arm or the local treatment arm. Local treatment, we use hepatic artery infusion chemistry, and the systemic therapy, we use the TKI plus the PD-1. All this regimen is very common in China, and we do 2-cycle treatment. And by now, 43 patients was enrolled, and 32 patients received operation. By the data now, we can see the systemic therapy and the overall response rate much higher than the local treatment. And we conduct another trial, use the same and the design, but we use the multiple tumor liver cancer. But we can see the result and the systemic therapy, the response rate, and similar to the local treatment. And this 2 trial is also tell us the solitary tumor and the biological behavior is very different with the multiple tumor. Maybe solid tumor has a good biological behavior and more response to the treatment. So current data shows that target IO regimen is better than local treatment. So there is another question arise, and is feasible to combine the target IO regimen with local treatment? And I know in China, some experts, they are trying to systemic therapy plus interventional therapy or plus SBRT, radiotherapy. But I think although the effectiveness of the combined regimen will be improved, but the safety, minimal invasiveness, and the cost efficiency are impaired. So which is not conducive to promote. So maybe I think in future, we should choose the more simple, more efficiency treatment is the best treatment. So in conclusion, with the expansion of surgical indications for HCC, there is a huge unmet need for patients with a high risk of recurrence of surgery. And IO-based therapy opens unlimited possibilities for perioperative treatment of HCC. New adjuvant therapy will be a new hotspot for exploration for resectable liver cancer with high recurrence risk. Thank you for your attention.
Thank you, Professor Song. And now you have the last presentation to be Professor Ying, Strategies Innovation of Breast Reconstruction. She is Professor Ying is specialized in breast surgery, oncology, and oncoplastic. She excels as breast reconstruction, breast aesthetic surgeon, and microvascular surgery. Her techniques and results have made her a leading instructor and lecturer at national institutions, societies, and conferences. To help advance the field of oncoplastic surgery, Professor Ying conducts research and clinical trials, outcomes of breast oncoplastic surgery, and publishes widely. Last year, I had the opportunity to visit Professor Ying in Tianjin, the new breast center. That's incredible. It's a hospital with 650 beds, only dedicated to breast cancer. They treat 8,000 new cases a year of breast cancer. It's really unique. And she told me at that time, I was impressed with the number, but she said, this is the third in size in China. We have Beijing and Shanghai that are bigger. Then they are working in this multidisciplinary team in centers really specialized in special types of cancer. And of course, these are allowing then this fantastic development that the oncology in China is doing. Professor Ying, thank you very much for coming. The floor is yours.
Dear academician Costa, thank you for your invitation and thank you for your introduction. This is my first time to Brazil. I do enjoy this here. It is my great honor to introduce the strategies and innovation of breast reconstruction in China. In July 2023, under the leadership of academician Daiming Fan, we published a guideline of oncoplastic and reconstructive surgery. The onset audience is over 1,500 with 33 million online. The reason for this high publicity is due to the increasing incidence of breast cancer and increasing demand of oncoplastic breast surgery. In China, there are 420,000 breast patients who are diagnosed with primary breast cancer annually. The rate of breast conservation is about 20%. The rate of post-mastectomy breast reconstruction raised from 4.5% in 2012, raised to 10.7% in 2017. We saw the increase in reconstruction. About 300,000 female patients still face the challenge of breast loss. It is our aim to raise awareness and practice of breast reconstruction in China. Therefore, we need to optimize our strategies and innovation skills. In the accept of strategic optimization, CACA guideline emphasize on holistic and integrative treatment. We focus on oncological safety as well as quality of life. The holistic and integrative treatment is foundation. To clarify this, let's take an example. For such a patient with locally advanced breast cancer, according to CACA guideline, we give her neoadjuvant chemotherapy and evaluate the effect every 2 cycles. After completion, autologous flap was used to repair the chest wall defect, followed by radiation therapy. Oncological safety is the top priority. We don't recommend to sacrificing oncological safety to decrease the complication rate and improve the cosmetic result. Flap thickness in Western countries cannot be readily used to our patients because of the characteristics of small size and glandular type of breast amount and a younger age at diagnosed. CACA guideline recommends thin mastectomy flap to our patients. Quality of life is also our goal. CACA organized a lecture tour and workshops to train our physicians and refine their skills. The application of oncoplastic surgery has enabled extensive conservation. For such a patient with large tumor, the diameter is larger than 5 centimeters. We used to perform mastectomy, but now we will perform oncoplastic breast surgery. Numerous research on immediate breast reconstruction were conducted in Western countries. Our data also showed psychological benefits, accepted surgical and oncological safety of immediate breast reconstruction. CACA guideline recommended immediate breast reconstruction for early breast cancer patients if breast conservation is not advised. In the 2012 Warren NCCN guideline, if post-mastectomy radiation is required, delayed reconstruction is preferred after completion of radiation in the form of autologous tissue. However, in our practice, we found that some of the patients who underwent autologous breast reconstruction followed by radiation therapy didn't suffer from severe complications. Therefore, we move on to investigate the modality of immediate autologous breast reconstruction followed by radiation. The study show if post-mastectomy radiation is required, immediate breast reconstruction with autologous tissue can also be considered. The result was cited by the expert consensus on breast oncoplasty and reconstruction in 2018. NCCN modified the guideline in 2020 to include immediate autologous breast reconstruction as an option for patients requiring post-mastectomy radiation. The breast can be reconstructed by implant and autologous tissue. CACA guideline reference to use the simple methods to reconstruct it to achieve similar surgical outcome and reconstruct it while minimizing donor site complications. For example, this patient, the breast of this patient is very small. Although we can use deep flap to achieve good appearance, but the inherent long surgical duration and chance of fat loss should be taken into consideration. Therefore, according to a CACA guideline, we used extended latissimus dorsi flap to reconstruct the breast, followed by white grafting to achieve optimal outcomes. We also focus on the shape of the reconstructed breast as well as minimizing donor site defect. We can use pedicle tram, muscle sparing tram, and deep flap to reconstruct the breast. In our over 500 cases series of autologous tissue flap reconstruction, no significant difference were noted in donor site complications between deep and the pedicle tram group. Therefore, CACA guideline recommended pedicle tram for rural clinics where macrosurgery is hard to practice. In higher academic hospitals, deep is gold standard for free autologous breast reconstruction. We are now investigating the advantage of endoscopy-assisted deep flap to diminishing the donor site trauma and defects. In addition to strategy optimization, we are also dedicated to skill innovation and promotion. First, we try to innovate the work modality. In West country, immediate breast reconstruction requires a team of breast surgeon and a team of plastic surgeon. However, we face the challenge of no plastic surgeon in cancer center, and the collaboration between two teams may lead to delayed surgical treatment and different incision options. Therefore, in 2001, we start a new modality to perform the immediate breast reconstruction by one team. This modality increased the efficiency and improved outcomes and was widely adopted nationwide in China. Currently, 80% of the immediate breast reconstruction was performed by breast surgeon. In 2010, the first oncological breast surgery department was established in Tianjin. Afterward, many departments of oncoplastic surgery was established in several provinces, which promote development of breast oncoplasty. During the past 20 years, we dedicated to refine our skills and innovation with the aim to providing individualized reconstruction for each patient. In China, implant-based breast reconstruction is the major form of immediate breast reconstruction. CACA guideline emphasized on the standardized procedure for mastectomy reconstruction and post-operative care, which so that we can achieve decreased complication rate and better cosmetic results. The detailed standardized procedure is stipulated based on numerous clinical studies. For example, one study is over 1,000 cases revealed implant volume, implant coverage, radiation, blood glucose, and albumin levels were independent risk factors associated with major complications in prosthetic-based breast reconstruction. The results provide proper preoperative measurement for quality control. In the management of antibiotic prophylaxis, in contrary to other triple antibiotics in other countries, CACA guideline reference the prophylactic use of intravenous cefazolin or clindamycin 30 minutes before surgery initiation and 3 hours intraoperative. No post-operative bolus is needed. Investigation about comparing the complications of implant-based breast reconstruction revealed concurrent infection and wound discussions increased the rate of prosthetic failure by 14-folds. CACA guideline recommended early management of infection and debridement of wound adhesions to lower the implant loss. The detailed standardized procedure was also aimed to improve the cosmetic results. CACA guideline recommended the measurement of abdominal tissue thickness at inframammary level, in addition to 3 dimensions of breast for individualized implant selection. The application of mesh have improved the cosmetic results, prevent the donor site complications, and reduce the surgical duration. A cellular bovine pericardium is a kind of mesh made in China. Now we are conducting several clinical trials comparing its usage and outcomes between TALUC and ADM. With the detailed standardized procedure, we can see we have extensive use of implant-based breast reconstruction with different size and shapes of breast and a different degree of ptosis. Enhanced recovery after surgery is widely used in surgery. In 2022, CACA published a consensus, the first ERAS consensus on breast reconstruction in China. This consensus includes a wide range of 18 topics, including preoperative education, imaging evaluation, anesthesia, post-operative care, rehabilitation, etc. The consensus do make contribution in rapid recovery and reducing the complication rate. Due to the uneven development of breast reconstruction in China, CACA organized workshops, post-mastectomy breast reconstruction conference and the philanthropy initiative to train physicians and refine their skills. According to the CACA 2023 report, in a survey of 195 hospitals, 79% of the hospitals have less than 5% complication rates of prosthetic-based breast reconstruction, and 95% of the hospital have lower than 5% explantation rate. 84% of the hospital have less than 5% complication rates of autologous breast reconstruction, and 82% of the hospital have less than 5% rate of flap loss. The report also revealed that about 22% of the hospital didn't perform immediate breast reconstruction, and 44% of the hospital have less than 25% reconstruction rate. So in the future, it is our aim to focus on continued education and innovation and promote the breast reconstruction to improve the quality of life. Thanks for your listening. Obrigada.
Thank you very much, Professor Ying, for the very important work. This topic of reconstruction is very important because the afraid of mutilation for many decades has avoided many women to have the diagnosis and the treatment of breast cancer because of the radical surgeries in the past. In the last years was this progression of reconstruction. Surely all the women are much more with more adherence to the treatment and early diagnosis and getting much better quality of life. And I congratulate you for all your effort in China to try to spread this concept. Thank you very much, Mr. President. You have the...
Thank you, academic Maurício Magalhães. And now it's our pleasure to invite the academic Paulo Hoff for comments. Please, Paulo.
Distinguished President, dear colleagues, honored guests, it was very interesting to see all the discussions this morning. First, we had the discussions from our Brazilian colleagues calling our attention to the problems that we are facing and will face with the aging of the population and with the reality that we are not truly equipped to deal with this change in our epidemiology. And certainly, I think the point that has come across is that we, as the National Academy of Medicine, could work to try to direct or to help to improve the training and the national policies towards geriatrics. But I was very, very thankful to be able to participate and to see the presentation from our honored guests. And it's interesting to see like such a big country as China is facing problems that are not all dissimilar to what we are seeing here in Brazil when we deal with our aging population and the increase in the incidence of cancer. In Brazil, in the last 20 years, the number of new cases of cancer has almost doubled. We did have some significant steps. One of them that I would like to highlight because had participation of at least 2, if not more, of our academics was the decrease in the rate of smoking in our country. Marcos Moraes and Professor Jorge Costa Silva were paramount in the initiation of the programs that reduce the smoking rates in Brazil. And with that, we have seen over the last 10 years a decrease, a proportional decrease in the number of patients with lung cancer. But lung cancer remains a major problem in Brazil as it is in China. And we're very thankful and very happy to see the developing new treatments and new strategies for the diagnosis and for the treatment of lung cancer patients that was demonstrated today by our colleagues from China. And perhaps this is one point where we could truly collaborate in the development of new products, new drugs to treat cancer. We have a very large cancer population in Brazil, over 700,000 new cases per year. We have a very well-established infrastructure for treatment and for research, and we're eager to participate and help develop new treatments that will not only improve the efficacy of what we're offering to our patients, but hopefully also will decrease the cost and allow a country like ours to truly be able to treat all of our citizens the best way possible. And we see the impressive development of new drugs coming out of China as an opportunity. And certainly, I believe the National Academy of Medicine, working with our colleagues from China, could work to introduce and to make the connections between the researchers in both countries to allow this fruitful collaboration. And I'm certain that we could help and be strong participants in clinical trials developing new drugs, since we have very similar problems in the cancer area. And I could not miss the discussion regarding neoadjuvant treatment for liver cancer. In Brazil, liver cancer is a growing problem, and we have seen some impressive developments with the transplants and with the new immunotherapies, but we still have a long way to go. And I certainly share with our colleagues from China the desire to find new strategies that will allow the treatment for patients with liver cancer to be more effective and to be available to all of the population. I think we're a little over the time, Mr. President, and I think I will allow some time for my other colleagues to make the discussions as well, but I would like to congratulate Professor Maurício for the initiative to bring these two great societies together with us today, and to thank the President for choosing me to do some of the discussions. Thank you very much.
Thank you, Paulo. Your comments have been very appreciated. Thank you very much. And now I would like to continue with the comments from our academic, calling academic Daniel Tabak, please.
Madam President, members of the Chinese delegation, first of all, we'd also like to thank the organizers and Professor Costa for organizing and having this incredible amount of information that we had here today with the presence of such a distinct group from China. And we had the opportunity to see, as Dr. Hoff mentioned, some of the comparable issues regarding the problems with aging and cancer. And we started the discussion with the problems with, I could say it's summarized, as Dr. Moll mentioned, of inflammaging. This issue that we have so many problems and evolves not only in cancer, neurological disease, and I would say from my side, regarding blood cancers, as we see the new oncogenetic markers, they're coming associating the problems with vascular disease, and some markers like DMT3 and TET2, markers that have been identified and characterize some myeloid disorders. And I'm looking forward to see some of this association that could be done with also other cancers. And I understand that this could also be investigated in lung and liver cancer. So I think this is something that I would like to remark. We learned from Dr. Zhou the issue and the awareness, the preoccupation of the incidence of cancer in China as it is in Brazil. And again, I cannot make a less a point regarding the incidence of smoking and how the efforts that have done in China and Brazil regarding the decrease in this habit. And also this interesting that some of the issues that are not available here, but are being reinforced as that detection, early detection by the program of low dose CT scanning, and the way this is gonna probably change as we able to diagnose earlier lung cancer. I think this effort has not been accomplished still in Brazil, but something to be considered as patients could be diagnosed earlier. The other thing that I learned from Dr. Zhou, and this is really impressive, the turnaround time for the markers of the genetic markers for the diagnosis of early lung cancer that changed so many issues regarding the treatment of the disease. 4 days of turnaround of the markers is something that's really remarkable. As we see in our population, this really may take a couple of weeks to get the results, and this may delay the treatment on the patients. Also, the other thing was very interesting to understand, to learn, is the plethora of the new molecules that have been identified in China, and the way INO is becoming more accessible to the population at the lower cost. And unfortunately, this is still in Brazil, is still a major issue, as most of these drugs are still not available to the majority of the population. And it's possible, and we hope that with this collaboration, we could have some of the trials together, and we could make this effort available to the Brazilian population. This would be a major advance in the care of our disease. In the issue of heterogeneity, I thought that was very interesting because China has such a large population of patients with hepatocellular carcinoma. And I wonder if these issues about the incidence of hepatitis B virus and how this contributes, and I'm sure this is also being developed, some of the major contributions of the study of the microbiota. I understand that this is something that's also being studied in China, and the influence of the immune system and how this contributes to the major evolution of the disease. Regarding the new adjuvant therapy on hepatocellular carcinoma, I think this is going to be very important, especially in the small lesions, because those are patients that are amenable to have the surgery performed. And the issue of doing this is in this type of population that's usually not considered for RNO, it's certainly going to be, and it is, a major contribution. And I think this is also an area because hepatocellular carcinoma is also a very common problem in Brazil. So I think that this is an incredible opportunity. We had a great morning here with a lot of learning, a lot of interchange. And this is in a very fruitful possibilities that are coming the next few years. And I also very thankful to the Academy for this opportunity and the possibility to interact with our Chinese friends. Thank you very much, Madam President.
Thank you very much, Daniel. It was very appreciated. And now I would like to call academic Rui Haddad for his comments, please.
Thank you, Mrs. President. I would like to ask you permission to speak in Portuguese, to turn my comments faster and clearer, please. Thank you. And I ask you all to use the translator instrument, please. Eu fico, membros da mesa, convidados, colegas das chineses, eu fiquei muito impressionado com as apresentações, excepcionalmente impressionado. Como estou impressionado com a evolução exponencial da medicina chinesa nos últimos tempos. Na minha especialidade, que é a cirurgia torácica, eu tenho visto trabalhos assim realmente espetaculares nessa área vindos da China. Em todas as revistas americanas e europeias, que nós temos acesso direto, eu vejo trabalhos chineses da mais alta qualidade. E nós vemos, inclusive, que o presidente da International Association for the Study of Lung Cancer é chinês. Isso é uma espetacular. Eu estava comentando com ele antes da apresentação. Eu sou membro dessa sociedade desde 1985 e brinquei com ele, falei, provavelmente, antes de você nascer, eu já era membro dessa sociedade. Então, eu achei as apresentações assim, magníficas. Tá? Eu acho que esse relacionamento com os colegas que apresentaram aqui hoje vai ser realmente espetacular. E espero que nós possamos construir assim uns projetos assim maravilhosos brasileiros e chineses no futuro. Muito obrigado.
Thank you, Academic Rui Haddad. And then we would like to have the comment as well by Academic Fernanda Moll. Please, Fernanda.
Thank you. Thank you very much again for the invitation. So I'd like to say that it was a wonderful morning. Thank you all the delegation to be here. I think that from both sides of looking to aging in the first part of the symposium, understanding better the needs as Dr. Kalache started, and the other two also followed to actually training more our physicians in geriatric assistance, but also the integration, multidisciplinary, not only physicians, but our nurse schools and all the others, because the care is multidisciplinary and has to be done. So it's a long life learning. I think that also all the specialists need to understand that we need to learn more about aging overall, not only inflammation, but also then and brain disorders and all the cardiovascular systems, and also, of course, cancer. And I was delighted to hear from all the presentations from China. It's amazing what you have been done and is continuing to be doing in medicine overall. Of course, we learn here related to cancer, but I hope that events like that strengthen our collaboration with the whole Academy of China, and that we can also maybe increase and goes beyond cancer to the other areas as well. And I hope that to be able to count with our Academy, Ms. President, for that. Thank you again for the opportunity to learn today with all of you. Thank you.
Thank you, Fernanda. And now we are going towards the end of our session. And it is a great pleasure for our Academy to sign with the Chinese Anti-Cancer Association the Memorandum of Understanding. We are going to make a little change here in the table, and we will put the two chairs together to show our cooperation and to show that we really would like to pursue this type of understanding. Thank you.